Hello, everybody. I hope you can hear me. I think.
Yes.
Professor Tam, good evening. Dr. Beno Michel, good evening to you too. Good morning. Please, Professor, Dr. Beno, yes, exactly, the mic. So, my name is Mara from Hebrew University Division for Advancement and External Relations. I'm happy to introduce Dr. Beno Michel, one of Hebrew University's closest friends from Ohio and Florida. Dr. Michel and his wife Elaine have been involved with the Hebrew University and its American Friends Association since the 1980s, providing a staunch support for medical research and higher education at the university and in its Faculty of Medicine. They have generously founded the Elaine and Beno Michel MD Graduate Scholarship Found in Pharmacology, advancing graduate medical education. Professionally, Dr. Michel is widely recognized in his field. He has been teaching, conducting research, and practicing clinical dermatology for over 20 years. He is clinical professor of dermatology and assistant clinical professor of pathology at Case Western Reserve University, which he joined in 1968. He will introduce Professor Yossi Tam, our webinar speaker today.
Hello, everybody. I'm delighted to introduce Dr. Tam, whom I had the privilege of meeting shortly after he joined the faculty of the Hebrew University. Dr. Tam is the head of the Obesity and Metabolism Laboratory at the Hebrew University Institute for Drug Research and the director of the Multidisciplinary Center on Cannabinoid Research, which is focused on developing cannabinoid therapies to address a broad spectrum of diseases. Dr. Tam is very lucky to work closely with Professor Emeritus Raphael Mechoulam, who has been a pioneer in the field for the last 50 years. Dr. Tam earned his PhD at Hebrew University and got a dental degree from the Faculty of Dental Medicine. He did his postdoctoral fellowship in the United States at the National Institute on Alcohol Abuse and Alcoholism of the National Institute of Health, where he studied obesity and metabolic syndrome, which includes insulin resistance, diabetes, and coronary vascular disease. For his outstanding research, Dr. Tam is a recipient of 3 prestigious awards. So it's my pleasure to give you Dr. Tam. Thank you.
Thank you so much, Beno, for this kind introduction. It was a pleasure meeting you in the US, and here we again meet in this crazy time. So I do hope that you and your loved one are in good health and coping okay with this very challenging and unprecedented time. And today or tonight or this morning, depending where are you, I will try to take you to a journey about telling you about the role of cannabis and cannabinoids in different health conditions, tell you about my own research, others' research, and of course the Multidisciplinary Center for Cannabinoid Research that was established at the Hebrew University a couple of years ago. So let me share my screen with my presentation. No, it's not this one. Wait a minute. All right. So I hope you all can see my presentation. So it's a pleasure.
Yeah, yes. We can, and I would like to add that at the end of your presentation, we will open our question and answer session, so everybody can raise your digital hand or write in the chat your question, and Professor Tam will answer. Thank you.
Thank you, Mara. So I would like to start with a brief introduction into cannabis. And according to the Israel Ministry of Health, medical cannabis is not a medicine. It is not registered as a medicine, and its efficacy and safety when used for medical purposes has not yet been established. However, the second role or identification of cannabis by the Ministry of Health in Israel established that nevertheless there is evidence that cannabis could help patients suffering from certain medical conditions and alleviates their suffering. And therefore they established the IMCA, Israel Medical Cannabis Agency, at the Ministry of Health. So what is cannabis? It can be divided to two general products: hemp, which is mainly used for agricultural production, production of fibers, oils, and food, and marijuana, which has the pharmacological action via cannabinoids, THC and CBD, which I will further elaborate during my presentation. In Israel, currently, there are around 50,000 patients that are being treated with medical cannabis for different indications, such as cancer, not the malignancy per se, but the treatment and the side effects that are associated with the treatment for cancer. Also for chronic pain, Crohn and colitis, post-traumatic stress disorder, multiple sclerosis, Parkinson, AIDS, terminal illnesses, and Tourette syndrome. Let me take you back in the history of medical cannabis, and the first evidence, archaeological record of using hemp comes around 8,000 years BC. Later on, the first medical use of cannabis was known in China in 2700 BC, which was followed by the religious use of cannabis in India. Moving on to the 18th century, the Western world learns first time the bioactivity of cannabis and uses it as a product for alleviating pain. And from that, it brings us to the 19th century, where in the US there was the Marijuana Tax Act, which was followed during the 70s as putting cannabis as a controlled substance of abuse. And since then, the legal aspect, of course, the research aspect and the recreational use of it have been tremendously reduced in the US and also around the globe. But the first state in the United States that actually legalized cannabis for medical use was California in 1996. And since then, as you can see, American is in high, with over 30 states that have been approved the medical and recreational use of this drug. It's not only the United States that did this kind of dramatic change in its approach in favor of cannabis, but you can see that all over the globe, many countries have initiated different programs to use cannabis for different medical condition or use it legally for recreation. But I would like to take you back to this small country in the Middle East, Israel, where I believe that everything has started. And the work that actually started was initiated by Professor Raphael Meshulam, a young scientist back then at the Weizmann Institute, and later on moved to the Hebrew University, became director of the Hebrew University. He's the godfather of cannabis research, who identified the two active components in cannabis and actually characterized their correct structure, THC and CBD. THC, the psychoactive component in cannabis, as well as the CBD, the non-psychoactive component in cannabis. And based on these two drugs found during the 60s by Raphael Meshulam, we can categorize the different strains of cannabis and decide whether we use a high CBD or high THC products. But it took almost 20 years since this initial discovery is done in the 60s by Raphael Meshulam to understand that the psychoactive ingredient in cannabis, delta-9 THC, is actually activates a specific receptor, or it has a target in the brain, and it was cloned and identified as the cannabinoid receptors. So we do have cannabinoid receptors, CB1 and CB2, which basically are activated by THC coming from the plant cannabis. The presence of these receptors is all over our body, mainly in the brain and the central nervous system, as well as in many peripheral organs. Now, these receptors, you and I have those receptors, are present not because they are waiting for us to use cannabis, but because the body produces endogenous compounds, which were also identified by Raphael Mishulam and termed as endocannabinoids. Endocannabinoids, the two main endocannabinoids are anandamide and 2-AG, that basically activate and stimulate the cannabinoid receptors, CB1 and CB2, in a similar fashion as THC does it, although the structure of this compound is totally different. And these endocannabinoids are produced by almost any cell in our body, and any organ in our body can produce those compounds. And we can find these endocannabinoids in the blood. They circulate in the blood. Their concentrations are dynamic. They are highly lipophilic ligands, as well as they come from multiple organs and they shade into the circulation. And there is a thought that endocannabinoids can be served as an indirect marker for tissue endocannabinoid tone in different physiological, normal physiological, and pathological conditions. And why it is important? Because the endocannabinoid system is one of the main endogenous systems that regulates our physiology, such as the respiratory system, the digestive system, the endocrine system, the musculoskeletal, just to name a few. And in fact, the endocannabinoids activating the CB1 and CB2 are modulating different physiological effects. And these physiological effects that are basically highlighted in this slide can be also modulated by cannabis or THC coming from the plant. So let me take you into more specific effect of cannabinoids. We can differentiate the central effect of cannabinoids and the peripheral effects of endocannabinoids. In fact, CB1 receptor is the most abundant receptor in the human brain, and it is present in different parts of the brain. For example, in the hypothalamus. And if we consume cannabis or activating the CB1 receptor endogenously by endocannabinoids, it may induce an increase in appetite. But what happens if we do the same activation of the CB1 receptor in another brain area? For example, in the brainstem. Then it will induce nausea relief, it will lower blood pressure, lower pain, spasticity, and tremors. If we do the same activation of CB1 receptor in the cerebral cortex, it will change our memory, it may induce hallucinations, and of course, altered our consciousness. If we do the same in the hippocampus, it will induce memory impairment. And if we activate the cannabinoid receptors in the cerebellum, it will induce loss in coordination. And again, if we do the same in the amygdala, which is another brain area in the human brain, it will induce changes in anxiety, panic attacks, lower traumatic memories, and decrease hostility. So you can see that one receptor that is present in different areas of the brain, and the same activation of this receptor by either endocannabinoids or phytocannabinoids coming from the plant induces different effects in the human brain. And what about the peripheral effects of cannabinoids? So CB1 receptor and endocannabinoids are present in many tissues in periphery, which means that in the gut, activation of this receptor will induce fat ingestion. If we do the same in the pancreas, it will induce insulin release. It will reduce insulin sensitivity through activation of CB1 receptor in the muscle. If we do the same in the kidney, it may induce fibrosis. And if we activate the CB1 receptor in the liver or in adipose tissue, it will increase fat accumulation in these tissues. Again, same receptor, same ligands that activate it, and we get different effects. And so we really need to understand and decide in which physiological status are we. Are we in a situation where there is an hypoactivity of the endocannabinoid tone, so reduced activation, or in a physiological state where there is an hyperactivity of the endocannabinoid tone? Because by differentiating between these two conditions, we can decide upon which treatment with cannabis or other synthetic cannabinoids can be used. For example, if we have an hypoactivity of endocannabinoid tone, we will need to facilitate the endocannabinoid system to stimulate it in order to bring it back to normal and to balance. But on the other hand, if there are conditions of a hyperactivation of the endocannabinoid tone, we will need to block it and to bring it back to normal regulation. And I would highlight these two features later on during my presentation. But to add to this complexity, we should also think that there are effects in cannabis that are not modulated directly by the receptors CB1 and CB2, which are non-receptor mediated. And when I'm telling non-receptor mediated, I'm of course focusing on the different phytocannabinoids that are present in the plant. For example, CBD, which I briefly mentioned earlier. It was found by Raphael Meshulam and characterized by him as for the structure and the activity, but the effect of this compound coming from the plant is not directly through activation of CB1 or CB2, but other receptors, as you can see it here. And in addition to CBD, there are other phytocannabinoids, for example, CBG and CBC and CBDV, which also have physiological effects via an non-receptor mediated, via an unidentified receptor yet. And to add to this complexity, we know that as per now, there are around 140 different phytocannabinoids present in the plant, but also sugars and alcohols and aldehyde, but many terpenes and flavonoids, which also have some effects. So we should ask whether all of these compounds present in the plant cannabis do have an effect on our physiology. And when I'm combining all of them together and trying to highlight what is the role of the general effect of cannabis, we should use the term also termed by Raphael Meshulam, the entourage effect. So what is the effect of all these phytocannabinoids, terpenoids, flavonoids, and other compounds that we extract from the plant on our physiology? I would like to go back to this hypothesis of hypoactivation of endocannabinoid tone versus hyperactivation, and how do we, of course, modulate it using different drugs or different extracts coming from the plant. And I would start by the hypoactivity of the endocannabinoid tone conditions. There are different conditions that highlight such a position, but I would like to highlight one of them. And the one that I would like to highlight is autism, autism spectrum disorder. As you may know, autism is a biological disorder with multiple etiologies, which is featured by impairments in social interaction, impairments in communication between each other, and the presence of restricted and repetitive behavior. Now, we know that 50% of the children with autism have behavioral difficulties. For example, violent outbreaks, severe anxiety, tantrums, and 40% do not respond to the current medication and a therapy option. And as I mentioned to you, the endocannabinoid system is known to be implicated in the modulation of neuronal activity in the brain via the activation of CB1 receptor. And it's also modulating social and emotional reactivity behavior. And many studies that were conducted in animals suggest that there is an imbalance in the endocannabinoid system in different animal models for autism. So we tried to assess whether it's also present in humans, in children suffering from autism. So we collected blood samples from autistic children versus neurotypical children without autism, and we tried to assess the levels of endocannabinoids in their blood to know whether they suffer from hypoactivation of the endocannabinoid system or hyperactivation. And surprisingly, we found that patients with autism show a strong reduction in the levels of endocannabinoids in their blood. You can see here that anandamide level, the main endocannabinoid, is significantly reduced in patients with autism, but also other endocannabinoids, OEA and PEA, which I have not discussed today because of the time limit. But remember, there is an reduced levels of endocannabinoids in the blood of children with autism. So how can we actually manipulate it by returning these reduced levels to the baseline? Maybe it will also affect the behavioral paradigms of these children. In order to assess this, we remembered that 30% of the children with autism have also epilepsy. And actually, epilepsy and autism share a similar pathophysiological processes. And we know, based on different studies that have been conducted during the past 30 years, starting from Raphael Meshulam, that show that epileptic children can be treated with CBD. And CBD is recently approved by the FDA to treat epilepsy in the drug called Epidiolex. We know that CBD also has the ability to modulate endocannabinoid levels. So, of course, together with our clinicians, Dr. Adi Aran from Shaare Tzedek, who is a member of our center, we conducted an open label clinical trial in 60 children suffering from autism, which these children suffer from behavioral problems. They had some failure to proper medication, and they received a whole plant extract of CBD-rich cannabis strains and were followed up to 30 months. What we found in this study is that 60% of the people, of the children with autism treated with CBD showed an improvement in behavior. 50% showed an improvement in communication, and 40% showed an improvement in anxiety. This, of course, was an open-labeled study, clinical study, so the patient and their children and their caretakers knew about the treatment, so maybe they were biased. You can understand there was not a placebo control. So we decided to follow this study with another study done by Dr. Adi Aran, and this time an interventional control trial, a double-blind placebo control randomized with 150 participants with 3 arms. 1 arm receiving placebo and 2 arms receiving either whole plant extract of CBD and THC in a ratio of 20:1, and another arm with pure cannabinoids in the same ratio as the whole plant extract. Since this study has not been published yet, I cannot reveal the results, but I can briefly mention that the trial was very successful. Most of the patients that received the cannabis strain with a patient with autism show improvement in communication skills, behavioral deficits, and so on. And this was a very clean and unique study that actually opened up a multi-center clinical trials with autism all over the world. So now I would like to go back to this balance and between hypoactivation of endocannabinoid and hyperactivation, and this time highlight another feature on the other side. What happens if we have an hyperactivity of endocannabinoid tone? How do we block the activation of this system? And if we can do it, how do we do it? And for that, I would like to highlight
one San Francisco Girl Scout is proving a shrewd businesswoman, making money off the munchies. The Green Cross, a marijuana dispensary, posted photos to its Facebook page this week of 13-year-old Danielle Lay selling her Girl Scout cookies outside its doors.
After 45 minutes, she had to call for reinforcement cookies, backups. And her mother was quoted saying that she sold about 117 boxes in 2 hours.
Danielle and her mom did not want to be interviewed on TV, but Danielle's mom told KPIX she thought this was a good opportunity to both show her daughter different areas of their city and to have a mature conversation about drugs. The East Bay Express quotes Carol, "The girls learn that users are not drugged out. Many have serious needs and are just a little different. And they get very hungry after," said Danielle. Yes, a lesson about pot, but Danielle's marijuana money move is also getting her praise as brilliant, savvy, even genius. We're just surprised there's not a dude at the end of some of these headlines. KPIX spoke with the Girl Scouts of Northern California, and they're fine with where Danielle set up her stand. She will be back at the Green Cross Saturday, and some of the money made off of selling her cookies will go to research for Alzheimer's. For Newsy, I'm Lauren Zima.
So, what do we learn from this short movie about the endocannabinoid system and about cannabis? We basically understand that cannabis, as you all know, may increase the munchies effect. It will increase appetite. And based on this, and of course, many research studies that have been conducted by different scientists all over the globe, when I decided to open my lab at the Hebrew University, I was asking myself whether we can utilize the data coming from the plant and using plant cannabis for induction of appetite to actually develop drugs that treat for obesity, for metabolic disorders such as chronic kidney disease, fatty liver, osteoporosis, mitochondrial function, in order to develop drugs that will basically treat the metabolic syndrome. As you know, the metabolic syndrome is an array of different conditions such as diabetes, obesity, cancer, hypertension, fatty liver disease, cardiovascular disease, and it is a real problem all over the world, not just in the United States. But let's see what happens in the United States. You can see that for now, more than 1/3 of the US adults are considered obese. You can see here the CDC map showed how much people are suffering from obesity in different states, and this map changes dramatically throughout the years. And nowadays, around the globe, around 2 billion adults suffering from overweight, and of these 600 million people are obese, and obesity causes at least 280 deaths annually. Just to comparison, 62% of the population in Israel are overweight. So we are in the same direction as in the US. How do we treat obesity? By, of course, lifestyle intervention, surgery, and drug therapy. And how all of this is connected to cannabis, and how can we manipulate cannabis or cannabinoids for treating of these conditions? We, of course, need to go back to the different physiological effects that are modulated by cannabis or cannabinoids. But this time I try to highlight several of these effects in red, and we can sure say that if we consume cannabis or if we activating the endocannabinoid system, it may cause us to relax, eat, drink, rest, sleep, save and store, and conserve energy. And if we think about even further, all of these effects are hallmarks of what we call the thrifty phenotype. It's the same phenotype that helped humans survive evolution during frequent period of starvation. However, in our Western society of abundant food supply, sedentary lifestyle, and increase in lifespan, these effects became the main cause in the epidemic spread of obesity and the metabolic syndrome, fatty liver disease, chronic kidney disease, and all of these effects have been known to be modulated by CB1 receptor, by the cannabinoid 1 receptor. And therefore, many pharmaceutical companies and, of course, research scientists trying to develop drugs that actually block the CB1 receptor. And one such drug was indeed reached the market. It was called rimonabant. and it passed all the preclinical and clinical development and was very successful in blocking brain CB1 receptor to treat obesity and to treat the entire metabolic syndrome. However, an increased anxiety, depression, and suicidality ideation in patients that suffered, that were taken rimonabant, actually limited the usefulness of this drug, and this drug was withdrawn from the market. But as I told you already, CB1 receptor is not only present in the brain, it is present in many peripheral organs. And in fact, if one consumes fatty diet, there is overactivation of the endocannabinoid system, not only in the brain, but also in many peripheral organs, such as the adipose tissue, kidney, bone, and liver. And activation of CB1 receptor in these tissues may cause to fat accumulation and to development of metabolic diseases. For example, today I will highlight fatty liver disease. So non-alcoholic fatty liver disease is the hepatic manifestation of the metabolic syndrome, and it represents a spectrum of diseases, as you can see, from just a simple steatosis to non-alcoholic steatohepatitis with inflammation, cirrhosis, and hepatocellular carcinoma. In order to assess whether the endocannabinoid levels and tone are, of course, modulated in these conditions, we again collected blood samples from patients suffering from non-alcoholic fatty liver disease and measured endocannabinoid levels. And here, for surprisingly, we found an upregulation, an increase in 2-AG levels. You can see it here, both in females and in males suffering from non-alcoholic fatty liver disease. 2-AG is one of the main endocannabinoids, as I already presented to you, and it is found to be very highly associated with the condition of fatty liver disease. So how do we can block this overactivation? Of course, by a drug, but the drug was withdrawn from the market. And therefore we decided whether we can develop a new drug now that actually blocks the CB1 receptor, not only in the brain, but in peripheral organs, for example, in the liver. So since I'm a pharmacologist by training, I always like to cite Sir James Blake, the Scottish pharmacologist who won the Nobel Prize in 1988, who said that the most fruitful basis for the discovery of a new drug is to start with an old drug. And this is exactly what we did. We took the structure of rimonabant, the drug that was in the market and was withdrawn, and we changed it chemically in order to reduce the the brain penetration of this drug. We started the journey with over 1,000 different compounds, and we selected them and screened them. And finally, we highlight 2 different compounds. JD5437, for example, is one of these compounds. And when we give this compound to mice that suffer from obesity and fatty liver disease, we saw that it basically reduces the liver damage, reduces and eliminates all the fat that exists in these livers collected from these animals. And not only treating non-alcoholic fatty liver disease can be achieved by blocking CB1 receptor in periphery, but as you can see it here, almost all the conditions that are associated with the metabolic syndrome, such as diabetes, dyslipidemia, obesity, fatty liver, kidney disease, and even cancer, can be indeed improved or be ameliorated by CB1 receptor antagonists. So here we started with an idea to develop a drug that actually blocks the CB1 receptor. We moved to preclinical evaluation of the drug in animal studies, and an IND needs to be submitted to the FDA to start clinical trials. Clinical trials are, of course, very long. It takes around 6 to 7 years to complete different clinical trials, phase 1, 2, and 3, until the drug reaches the market. All this process takes around 12 years to develop a drug and cost around $1 billion. I would like to share with you the fact that with our drug, JD5437, we reached the phase of IND approval by the FDA, and of course, clinical trials to use this drug, JD5437, in fatty liver disease is currently being held in the United States, and soon we'll start. So by just explaining you today what I've been doing and what I've been focusing, I would like now to highlight more a general view of cannabinoids and cannabis. A few years ago, the National Academy of Sciences, Engineering, and Medicine in the United States prepared a brief review of 400 pages showing the health effects of cannabis and cannabinoids in different types of diseases. I would share with you some of its findings, and the main finding were that it is known and there is a substantial evidence that cannabis or cannabinoids are effective for chronic pain, for chemotherapy-induced nausea and vomiting, for multiple sclerosis, spasticity symptoms. There is a moderate evidence that cannabis can help sleep disturbance. There is limited evidence that cannabis or cannabinoids are effective for increasing appetite, multiple sclerosis, Tourette syndrome, anxiety, post-traumatic stress disorder, and traumatic brain injury. And according to the NAS, there is no or insufficient evidence that cannabis or cannabinoids are effective for treating cancer, addiction, anorexia, IBS, epilepsy, spasticity, dystonia, and Parkinson's disease. So suggesting that what I've already started my presentation, highlighting the fact that in Israel, for example, we give cannabis for epilepsy, and also the FDA has just recently approved it. The main idea of the NAS is that there are no or insufficient evidence that cannabis is effective for these conditions because there is basically no data available and no knowledge. And based on these finding, and of course the Raphael Meshulam visions that modulating the activity of the endocannabinoid system may have therapeutic potential in almost all disease affecting humans, we decided at the Hebrew University to establish the Multidisciplinary Center for Cannabinoid Research 3 years ago. And so let's see a short movie about the center. So this movie prepared by the American Friends of the Hebrew University basically highlights our center. But briefly, our center is a unique center, not only in Israel, but all around the globe, because it integrates and coordinates the research activities of multiple laboratories that are associated at the Hebrew University and its affiliated hospitals into an interdisciplinary network conducting research on cannabis, endocannabinoids, and different cannabinoids, synthetic cannabinoids. We are leading in the area of cannabinoid research. We are the only institution in Israel like this that is basically focused on cannabinoid research and among 5 different institutions around the globe. And we basically serve as an engine for innovation and early research and development. The studies that are conducted in the research area, conducted in centers, are focused on a vast array of ideas such as cancer, autism, pain, neuroscience, allergy, epilepsy, just to name a few. And the studies are conducted by 40 different research and prestige scientists located in all of these faculties and institutions at the Hebrew University, which means that we are dealing with around 300 people actively involved in cannabinoid research at the Hebrew University. The center is being managed by the president, Rafael Meshulam, who is very active until very now. And I'm the director. We have an academic committee that actually a steering committee that revise and change all the research funding that is given to the scientists and so on. And our objective is to stimulate and coordinate interdisciplinary scientific research project and international collaboration to better understand the mechanism effects of cannabinoids. We cultivate close interaction with other research centers around the globe and also in Israel. We foster interaction with industry in order to translate our basic finding into commercial value. We encourage graduate students to concentrate on the research on cannabinoids, and we organizing an annual symposium on cannabinoids that brings together scientists, students from all over the world. And I would like to invite you next year to the 31st annual International Cannabinoid Research Society Symposium that is going to be held here in Jerusalem on June 20 to 25, which is going to, it's the first time after establishing this community, international community, that everything is going to be held here in Israel and featuring the Hebrew University and other research activities in Israel and around the globe. I would like to give you a taste for some of this research that are conducted in our center. We, for example, developed new extraction procedure for isolation of plant cannabinoids. We testing the efficacy of cannabis on different medical conditions. We designed novel drug delivery system for cannabinoid drugs. We assess the role of endocannabinoid system in allergy, define the psychiatric role of cannabinoids, and we test the antibacterial and antifungal effects of cannabis and cannabinoids. In numbers, our success over the past 3 years since the center was established, we published over 50 research articles. We licensed more than 20 patents to different commercial companies, and actually almost a quarter of the licenses in Yisum, the tech transfer company of the Hebrew U, is related to cannabinoids, and we raised over $14 million to conduct research on cannabis and cannabinoids at the Hebrew University. Our success academic stories involve getting funding from non-profit organizations such as the Ministry of Science and Agriculture, and also from the Israel Science Foundation, the European Research Council, and the German Israel Foundation, as well as we have different collaboration models with industry, with companies, which can establish different programs in our center based on the funding available from these companies. And these are the few companies that decided to initiate collaborations and grant to fund research in our laboratories, and basically fund and license all the technologies that are being developed by the Hebrew University scientists. So we believe in research, we believe in well-funded research in order to make new discoveries into cannabinoid research. And I, of course, welcome you to send me any question related to the activity that is done at the Hebrew University. And by that, I will finish my presentation, and thank you so much for your kind attention.
Thank you very much. Thank you for your very interesting presentation. We have already a few questions. Daniel Tawil, he raised his hand. I allow you to talk. You can open your microphone. Daniel Tawil. Okay, let's see if Harvey Glasner, he also, okay, we have now Daniel. Daniel, can you speak?
Hi.
Yes. Hi, you can ask your question.
Hi, Professor Tam.
Hi, Daniel, how are you?
Fine, fine. I wanted to know what is going on with cannabis outside Israel.
This is a very huge question. So what do you mean? In the government perspective, so where outside Israel?
Well, let's say what happened in South America and the government of South America and the future of cannabis.
As far as I understand, there are different regulations in South America. For example, in Uruguay, it is the use of cannabis is legal. We see some activities of legalization for medical purposes in Argentina, in Brazil nowadays. So I believe that in the future we will see more trials that are testing the efficacy of cannabis and cannabinoids in different medical conditions in these countries. However, I think that these countries need to be well educated about the effects of cannabis, because as I showed you in my presentation, cannabis is not a drug of wonder. Okay, we cannot treat all the conditions. There are some side effects that can be associated with cannabis, and educating the clinicians to better understand for what cannabis can be good and for not what are the side effects would actually promote the clinical use of cannabis in these countries.
Okay, thank you very much, Professor Tam.
Thank you. Now we have Harvey Glasner. Harvey, you can ask your question.
Thank you. I'm asking a question about musculoskeletal. What successes have you had, if any, on using CBD for musculoskeletal issues?
So actually, this is a good point. All the identification of the endocannabinoid system in the skeletal tissue was initiated almost 20 years ago by Professor Itai Bab, who passed away 5 years ago. Who was my mentor during my master and PhD, and we characterized together the involvement of the endocannabinoid system in skeletal remodeling, in bone mass in general. There are both receptors for cannabinoids, CB1 and CB2, are present in the skeletal muscle tissue. Endocannabinoids can be produced in this tissue, and we have shown that regulation of bone remodeling is totally different if you activate CB1 or CB2. Activation of CB2 has a positive effect on the skeleton, and you can actually do it by, of course, using cannabis. However, to activate CB2 in the skeleton using cannabis, you will need to, of course, use high THC levels, which is not beneficial for other conditions. So there are trials that we are initiated here at the Hebrew U to activate the CB2 receptor, specifically with the specific drugs that target the skeletal tissue. And what we also have shown that, in fact, going back to the plant cannabis, that CBD is beneficial to improve broken bones and facilitate their process of regeneration. This, of course, has been done only in animal models, and it will need to be further validated in clinical settings.
So just a follow-up question. Could you see some benefit in terms of the aging process where osteoporosis or tendon degeneration, et cetera, there might be some positive outgrowth from CBD?
We don't have the information yet. We do see that there is a reduction, there is hypoactivation of the endocannabinoid system in osteoporosis in animals, and we soon maybe will find it also in humans. We don't have the data yet to share with you. What we also identified is that that specific compounds related to cannabis or endocannabinoids are also greatly reduced in the skeletal tissue of osteoporotic patients as well as animals. And we found that these specific molecules that can be now being developed toward the market in order to improve the skeletal mass. But it's still not approved for clinical use.
Thank you.
Thank you. I'm now opening the microphone of Mari Simiu. Mari Simiu, you can ask your question. Mari? Okay, so.
Hello?
Yes, we can hear you.
Okay, thank you so much, Professor Tam. My question will be, is there any sufficient evidence to show that the cannabinoids can be used in the treatment of migraine? Because you had indicated that it can be used for the treatment of the chronic pain, considering the physiology of the migraine headache. And the second question will be, is there any evidence to show that cannabinoids can be used in, especially the newborns, considering that they're still developing immediately after birth? Thank you.
I couldn't hear the second question. Could you please repeat?
Yeah, within the newborns, are the CB receptors fully developed so that if there's an indication for them to use the cannabinoid, it will be effective? The receptors, are they developed in the newborn?
In the newborn? Newborn.
Yes.
Okay. So
yes.
First, to answer your question about migraines, there is a lot of data indicating that there is hypoactivation of endocannabinoids in different pain conditions as well as migraines, and that cannabinoid treatment is beneficial to treat these conditions. We, of course, suggest to use more CBD rich compound rather than THC. And this is about the migraines. About the second question, whether newborns have cannabinoid receptors that fully develop, the answer is yes. So cannabinoid receptors have been shown to be evolutionary, expressed in different species, of course, including humans, and the receptor is important for development as well, and therefore it is fully developed already in the newborn.
Thank you. We have now Dana Elner.
Hi. My question is about the general, you use the terms of hypoactivity and hyperactivity of the endocannabinoids, but my question is, how does the opposing effects of the CB1 and CB2 receptor play into that? So, for example, when you talked about the intervention controlled trial with the participants, you mentioned I think it was, you talked about anandamide, but not 2-AG, which focuses more on the CB2 receptor. So I'm curious as to how that plays in, and how do you control for unwanted effects due to the CB2 receptor, as well as unwanted long-term effects due to modulation of the cannabinoid system in childhood.
Okay, so these are a few questions. I tried during the presentation to simplify it, talking about endocannabinoid tone. When we talk about tone, we don't just measure the ligands, anandamide or 2-AG, but also the receptors, which could be either overexpressed or downregulated. This, of course, cannot be done in humans because we cannot collect tissues from humans, of course, but in animals. But as we see it, changing the tone can be, in order to bring it back to normal, might be a good approach in different conditions. Now, the CB1 and CB2 are not featuring the same activity or the same direction during activation. While CB1, for example, is activation of CB1 has a pro-inflammatory properties, activation of the CB2 might be an anti-inflammatory properties. So they kind of have an opposing effect and relationship. And when you activate the one, maybe the other one is being trying to compensate for the other receptor and vice versa. We cannot right now differentiate the activity of these receptors by different endocannabinoids or by phytocannabinoids. Of course, they have different specificity for the ligands, but this, of course, tested only in vitro, in cell cultures. In the human, in the whole organism, it's very hard to differentiate their activation by specific ligands. And therefore, we need to develop new tools, genetic tools, in order to feature the role of one receptor versus the other receptors. And we do it on a regular basis in the lab using animal studies. You had one more question, but I cannot remember it. So if you can repeat.
Yeah, just about the, if you do the controlled trials with children with autism,
Okay. Yes.
the cannabis could have, or where do you take into account the long-term effects of modulating the cannabinoid system at an early age?
Yes. So we know that it is well known that activating the CB1 receptor during childhood or adolescent is not the proper way and may have some side effects. And therefore, in this clinical trial, we try to reduce the amount of THC used versus CBD. We use a ratio of 20:1 CBD to THC. And we know specifically that the very low levels of THC are not causing any side effects, but needs to be there in addition to the CBD, which is in higher proportion to the CBD. We have some preclinical data showing that activation of CB1 receptor during adolescence, for example, is problematic. In mice, at least, if we compare, this is a study that was conducted not by us, but by Andreas Zimmer from University of Bonn in Germany, who showed that there is a differential value of endocannabinoid tone in adulthood versus aged animals, meaning that old mice have reduced tone and young mice have elevated tone. So if you take and you, in addition, you activate the CB1 receptor with THC, for example, in young age, you add on to the already activated system, which may cause a decline in cognitive function and so on. But if you do the same in old mice, which have a lower activation of the endocannabinoid zone, and you give them THC, you activate the receptor, you basically improve cognitive function of these animals, suggesting or highlighting the translational aspect of maybe in the future use a very low levels of THC to old people in order to reduce their chances to suffer from Alzheimer's disease or cognitive decline. This is, of course, was done in animals, but maybe will be translated to humans in the near future.
Thank you so much.
Thank you. Now our Dr. Beno Michel, you also have a question I can see. Do you want to open
Yeah,
your...
actually,
Yes.
two questions. What do we know about receptors in the skin? As a dermatologist, I'm curious about any evidence for receptors in the skin.
Yes, so the skin, the major organ of our body, indeed has the receptors, the CB1, CB2, but also other receptors that are being modulated by CBD. CBD, I didn't mention it during my presentation, does not activate the CB1 receptor or CB2, not in the regular and fashion of like THC does it. It activates other receptors, for example, PPR alpha. And these receptors are also present in the skin. So there is possibility to modulate the skin with cannabinoids coming from the plant or, of course, synthetic cannabinoids, either by activating cannabinoid receptors or other receptors that are modulated by cannabinoids and phytocannabinoids.
Are there any studies in skin disease like eczema or psoriasis that you know of?
In our center, Professor Ron Cohen studied the effect of cannabinoids on skin behavior. To be honest, I'm not familiar with his studies and finding so far, but I can really connect you with him and he will further elaborate.
And if there's time, one unrelated question. Some drug companies, instead of using the plant extract, are synthesizing chemicals similar to what's in the plant. Is that likely to be a trend to the future where people will get away from the plant itself and the stigma associated with the plant and just use synthetic chemicals similar to those in the plant?
I think that both pathways will be coexist using phytocannabinoids coming from the plant by to different conditions, as well as synthetic cannabinoids, which will be much more pure and can be approved even for patent and conditions and further be in the market and get the approval by the FDA. You saw the effect with Epidiolex, which is 99% CBD extract coming from the plant. But on the other hand, you can use the same CBD synthetic cannabinoids to treat the same condition. Why it is not being used now? This is a regulatory question that needs to be asked the FDA, but maybe in the future we will be able to use synthetic cannabinoids as well that will pass all the clinical evaluation properly and show efficacy maybe similar or greater than phytocannabinoids.
Thank you.
Thank you. I'll now open the microphone of Fred Lurie. Fred? Fred, you can now talk and ask your question.
Yes, thank you, Professor Tam, for an extremely interesting presentation. I was just wondering, I hear a lot about CBD for anxiety, and you can get it anywhere in the United States, even in gas stations. Whether it's legal, recreationally, or medically, you can get CBD everywhere. I was just wondering what the evidence is for its efficacy for anxiety.
So the rationale of using CBD as an anti-anxiety molecule comes actually from the fact that during anxiety, conditions, there is hypoactivation of the endocannabinoid tone. And by using CBD, it basically can modulate the endocannabinoid tone and increases anandamide levels in the brain, which will reduce the anxiety. So this is the research rationale that behind the use of CBD. There are some clinical data about using CBD, mainly for post-traumatic stress disorder or anxiety disorders. And it is in fact one of the clinical indication, at least in Israel, that patients are giving CBD to reduce their anxiety attacks and so on. If we take, for example, the opposite direction, using THC may cause anxiety attacks via activation of the CB1 receptor at very high levels. So one should be cautious of using high THC product in order to reduce anxiety and use more high CBD ones. But I'm not a clinician, so I'm just telling what is known from the literature. Of course, it is not a recommendation to use it for anxiety, but of course, get the proper evaluation by the clinicians.
Thank you. Thank you very much.
Thank you. I think we have time for one more last question. And David Stambler. David?
Yes, hello. Really insightful presentation. I also want to congratulate you on gorgeous slides. The design was beautiful. My question, I'm calling from Canada. We have many seniors suffering from extreme arthritis pain, and many are on strong pain drugs like fentanyl to manage this. But as the arthritis pain increases with age, increasing the pain medication is really not feasible. What are your suggestions about the types of CBD and dosage that would help with this chronic pain?
I would not recommend anything right now. As I said, although I'm a clinician, I'm a dentist, but I'm not a rheumatologist, and I cannot definitely suggest the dose, the proper dose, but in fact, treating chronic pain with cannabinoids has been shown that you will be able to, if it is given together with a pain drug, to first reduce the dosage of the painkiller, and using CBD will assist in alleviating this pain condition. If you want to get more specific information, I can connect you further with our expert in the center, Professor Eliad Davidson from Hadassah Medical School, who is a pain expert and one of the prestige doctors here that prescribe cannabis for different pain conditions, including the ones that you mentioned.
Thank you so much.
Thank you. So we reached our last question. Thank you to everybody. Thank you, Professor Tam. It was super interesting. And thank you, Dr. Beno Michel, for your introduction. It was great to hear everybody and voices from all the world and questions from really all the continents. So thank you to all, and hope to see you in our next webinars on Wednesday. You will receive tomorrow the recording and the list of our next webinars. Thank you, everybody.
Thank you so much. And good night or good morning to all.